So Dr. Svatek talked to you a little bit about the layers of the bladder and the staging, and it's important to note, as you can see on this slide, that the stages of the bladder cancer really depend on the depth of invasion. And when we talk about recurrence and progression, the most important factors are the depth of invasion and the grade of the cancer. And bladder cancers are either low grade or high grade. So one of the most difficult aspects of bladder cancer is its high propensity for recurrence and progression. And when we talk about recurrence, we mean the same cancer comes back at the same stage and grade. So if you had a non-invasive high-grade cancer, the cancer can recur as a non-invasive high-grade, and that would be termed a recurrence. A progression, though, means the cancer got worse. So it either went from low-grade to high-grade or from a non-invasive to an invasive tumor. Low-grade tumors are mostly considered nuisance tumors in the sense that mostly they recur, which is a good thing. They very rarely turn into high-grade cancers, and they very rarely progress to invasive disease. Once you get to high-grade cancers, though, the risk of invasion increases significantly, and a non-invasive tumor might become invasive into the lamina propria as high as 40% of the time and invade the wall of the bladder as much as 25% of the time. If it's already invading the lamina propria, in which case it's a T1 tumor, about a quarter of patients have that diagnosis at that stage of diagnosis, but these tumors are much more likely to recur and progress in a relatively short time frame. Carcinoma in situ is also a high-grade non-invasive tumor. It's usually a flat tumor, and it most often happens with other tumors in the bladder, and it's also associated with a very high rate of recurrence and progression. There are different ways for us as clinicians to identify risk factors for patients and predict the likelihood of recurrence, and that's based on primarily the number of tumors that somebody has, the size of the tumor, whether or not they've had many tumors in the past or whether or not this is the first tumor, and then the stage, whether or not they have invasion of the lamina propria, carcinoma in situ, and then finally the grade. This is an older grading system, 1, 2, 3, but really 1 is low grade and then 3 is high grade and 2 fall in between. This is a figure, and what this really shows is that if you take the different risk factors and you add them up, and you can get a recurrence score. And what it basically shows is that obviously those with the highest numbers, highest score are at a very high risk of recurrence. You can see at 2 years as many as 80% on the very top curve. But even the patients who are at very low risk, the solid dark line, have a risk of recurrence at as high as 20 to 30% over the first 5 years. So there is no group of patients with what I would consider safe bladder cancer. The good news is that progression to muscle invasion is very rare, at least in the very low risk group, which is we see a nearly flat line down there by the 0%. Unfortunately, the risk rises pretty quickly, and as you have more risk factors, the risk of progression rises fairly dramatically, and there are some patients who are at quite high risk for progression, which is concerning. As was mentioned earlier, we use treatments in the bladder to try to reduce the chance for recurrence and progression, and we wait for the bladder to heal from the initial resection about 2 to 6 weeks, and then we give treatments primarily to patients at higher risk for recurrence, and those patients with carcinoma in situ, and rarely those patients who we cannot completely resect their tumor. Mostly this means intermediate and high-risk patients. Those patients with solitary low-grade tumors are such a low risk for progression that we usually spare them the side effects of the treatments in the bladder. The main treatments that we give are BCG, which is a live and attenuated form of tuberculosis. And we don't know exactly how it works. We've been using it, though, for over 40 years. And the main way we think it works is by stimulating the immune response to fight bladder cancer. The alternative to that is chemotherapy, which works to kill cells and keep them from dividing. Interestingly enough, though, there are many studies that have shown that BCG is superior to chemotherapy, largely because the chemotherapy does not get absorbed by the bladder wall. And so even though it's quite effective at killing cells, if it can't reach them because they're deep to the lining, then it's just then it can't work well. And so BCG works in about 60–65% of patients initially, and the chemotherapy about 30–40% of the time. So we're talking about clinical trials, and these treatments, these intravesical therapies, are an important area where clinical trials have been very beneficial to us. And certainly we've been very appreciative that patients have been willing to participate in these trials. As I mentioned, when people started using BCG about 40 years ago, and even today, we don't know exactly how it works, but we wanted to find out whether or not it's more effective than chemotherapy or not. And so there have been many studies comparing BCG to giving different types of chemotherapy and whether or not you should use maintenance therapies. And the bottom line is that through these clinical trials, we've been able to find out that not only does BCG work better than the chemotherapy, but it's important to do maintenance treatments. In fact, for high-risk patients, it's important to do not only maintenance, but 3 years of maintenance at a full dose compared to reduced doses, which we use sometimes in patients with lower-risk disease or patients who are having a lot of side effects. And we also know that based on trials, BCG is a first-line therapy for carcinoma in situ because it works twice as good as chemotherapy in the bladder. Why do we still need to do trials? Well, the problem is that BCG doesn't work in everybody. You can see here in this graph that the blue columns represent what happens after after the first cycle of BCG. In other words, patients who have never gotten BCG before, it worked in about 77% of patients, and only 7% of patients developed invasive disease or metastases. But in people who had previously gotten BCG who recurred, and now you give them another cycle of BCG, you see the response rate goes down and the risk of invasive disease and metastases goes up. Finally, you see that if you failed after 2 cycles of BCG, or more, I should say the BCG failed you, you'll find that it only works 20% of the time by the time you give a 3rd cycle, and that's in the odds of metastases goes up to 50%. So after 2 cycles of BCG, we don't think that giving more BCG is a good idea if the cancers didn't respond because of the high likelihood that it won't work and that metastases will occur. So the guidelines for patients who have a recurrence after BCG basically say that if you need to resect all of it, and if you have lamina propria invasion, you might need to re-resect to make sure you don't have additional tumor. But this is the point where we have a problem, is that we should consider removing the bladder because of the fact that our alternative treatments are not very good, and giving more BCG is not very good. But there are options, obviously, to give other intravesical therapies, and this is where clinical trials right now play an important role, because we're trying to find out if we have other treatments that are effective so that we can avoid having to take out the bladder. This is a somewhat complex figure, but what it shows you is that these are sort of national guidelines for patients who don't have a complete response to BCG. And what you can see, again, is cystectomy or bladder removal is one of the top options. Changing agents is an option in some patients, but it's important to note that the guidelines recommend clinical trials as an important consideration for patients, because we know that what we're doing right now is not good enough for many patients, and we still prefer to avoid removing the bladder if we can, to spare some patients the decrease in quality of life. So just to let you know sort of why we want to avoid cystectomy is because there are obviously side effects. On the other hand, removing the bladder when the cancer is still confined to the bladder is the best chance of cure. It's definitive treatment. You don't have to worry about recurrences and progression as much, but we worry about quality of life implications. The benefits of intravesical therapy is that you preserve the bladder. On the other hand, there's a chance that the cancer will progress or spread while you're trying to keep your bladder and trying other treatments, and you might end up dying of bladder cancer, which could have been preventable.